The People's Pharmacy podcast is supported in part by CocoVia. CocoVia cocoflavanols support both cardiovascular health and cognitive function by promoting healthy blood flow, transporting oxygen and nutrients to vital organs and muscles, including your heart and brain.
CocoVia now comes in an even more concentrated formula, with 450 milligrams of cocoflavanols, 5 times more than the leading dark chocolate bar and 15 times more than the leading cocoa powder.
CocoVia has a proprietary process that preserves cocoflavanols at the highest levels, and the product undergoes rigorous testing at every stage, which allows them to guarantee the highest level of cocoflavanols per serving and to provide the purest, highest quality product possible.
People's Pharmacy listeners can now try CocoVia for 25% off by using the code Peoples25 at cocavia.com. That's COCOAVIA.com.
Coronavirus infections are overwhelming hospitals in many parts of the U.S. and around the world. What do you need to know? This is the People's Pharmacy with Terry and Joe Graydon.
There's so much uncertainty and anxiety around this pandemic. How can you make informed decisions about your health? What questions do you have about COVID-19?
Our guest today is an expert in infectious diseases and epidemiology. Dr. David Weber is standing by to answer your email questions. You can reach us now at radio@peoplespharmacy.com.
Coming up on the People's Pharmacy, answers to your questions about the COVID-19 pandemic. Send them to radio@peoplespharmacy.com. Welcome to the People's Pharmacy. I'm Terry Graydon. I'm a medical anthropologist.
And I'm Joe Graydon. I'm a pharmacologist. Today, we're offering you a live coronavirus update. We've asked our guest to answer your questions over his telephone.
To minimize the number of people in our WUNC studio and keep everyone as safe as possible, our technical assistant is not present. So, we will be taking your questions by email. That address is radio@peoplespharmacy.com.
Our guest today is Dr. David Weber. He's professor of medicine in the Division of Infectious Diseases and professor of pediatrics at the University of North Carolina School of Medicine. He's also professor of epidemiology at the Gillings School of Global Public Health and medical director of UNC Hospital's Departments of Hospital Epidemiology, Infection Prevention. Dr. Weber is Associate Chief Medical Officer of UNC Healthcare. Welcome back to the People's Pharmacy, Dr. Weber. Thank you so much for joining us.
Thank you. It's a great pleasure to be here to talk to you about how people can best manage through this pandemic.
Dr. Weber, we want to thank all of the hard work that you have been doing at UNC to get prepared for this pandemic, and we want to thank all of the healthcare providers and first responders who are taking the brunt of this extreme situation.
Dr. Weber, you were directly involved with UNC's SARS response in 2003. Can you tell us a little bit about that experience and how it was different from what we're going through today?
So SARS, as did COVID, originated in bats, as you mentioned, in 2003. Worldwide, there are about 8,000 cases, but through physical distancing and good public health, we eliminated that virus over a period of a number of months. United States only had 8 cases, fortunately, and I personally took care of the 8th and last lab-confirmed case of SARS. But we learned a great deal about coronaviruses that are applicable to our prevention of COVID from that outbreak.
Now, Dr. Weber, I wonder if you can give us an update on the statistics regarding COVID-19.
Certainly. Worldwide, there are more than 500,000 cases and more than 25,000 deaths. Here in the United States, we have more than 100,000 cases with greater than 1,500 deaths. And as you know, there have been particular hotspots such as New York, Detroit, a rising hotspot, Washington, based around the nursing home outbreak, and parts of California.
Now, there's something called a doubling time. Can you tell us what that means and what it is as of today?
So the doubling time is the time of which the number of cases would double. This is logarithmic growth. So for in the United States at the present time for COVID, it's on the range of 3 to 4 days, which means that 3-4 days from now, there'll be 200,000 cases in the United States. And at the end of a week from now, there'll be roughly 400,000 cases in the United States, unless we see this physical distancing beginning to decrease the rate of increase.
And I assume that actually is the point of physical distancing, is to slow down the numbers of people who are getting sick all at once.
Indeed, and that relates to how the disease is transmitted. We know it's droplet contact is the primary means of transmission, meaning within 6 feet, and direct touching. To some extent, there's indirect contact, meaning I rub my nose, I touch a doorknob, the virus will survive on surfaces for hours today. Someone touches that and rubs their nose. That's probably less important than the closeness. So if people stay apart from each other, then there really is no way for the virus to go from person to person.
Dr. Weber, there have been 2 events that have had a huge impact. I think there was a soccer game between, is it Italy and Spain, Terry? And also, of course, Mardi Gras. And it seems like those events where huge numbers of people were in close contact led to dramatic increases a week or 2 after the event.
Yes, absolutely. So again, it's a closely transmitted disease. So if you put people in close proximity, particularly for long periods of time, and we've seen this, of course, on cruise ships, nursing homes, the hotel outbreak in Boston. I suspect one of the reasons that we've seen so many cases in New York are subways, again, people closely packed. So yes, when you put people close together and you have susceptible people and infected people, then you get transmission.
Dr. Weber, what's the nature of this novel coronavirus? Why is it worse than influenza?
So, of course, there are several reasons that it's worse. One, of course, is unlike influenza, many of us have had influenza over the years, and while the virus mutates a little bit each year, we probably have some partial immunity. Here, all of us are susceptible to this new coronavirus, which originated in bats and then spread to humans, so none of us have any susceptibility, any resistance to it. And just intrinsically, this virus seems to have a higher mortality and cause more complications than does standard influenza.
Well, when it comes to complications, in particular, we've heard that older people are at the highest risk. But the CDC just issued a report on confirmed cases. 65% of them were between 20 and 64 years old. And when we just look at hospitalized patients, 55% were between 20 and 64. Have we given younger people a false sense of security?
We have. This may be partly that older people have been more physically distancing than younger people. Certainly, the mortality in older people, it certainly increases with other viral respiratory diseases like influenza, but it's much more apparent with this disease. So certainly it may just be a mixing issue. The other possibility is in 19, the flu pandemic, we did see more of what we call a W-shaped curve with substantial amounts of morbidity in younger people, which may have been due to their very vigorous immune response. Right now, I would say it's more likely we have more contact between the younger people than with older people.
Thank you so much, Dr. Weber. We're going to start taking messages from our listeners. You can join the conversation. We are live. Radio at peoplespharmacy.com is the email address. If you would like to email us questions for Dr. Weber, we do have one phone call. Sandy in Wake Forest, North Carolina, welcome to the People's Pharmacy. You have a question for Dr. Weber.
Yes, thank you, Dr. Weber. I have 2 questions. They are about paper items and food. We still get a paper newspaper and, of course, mail every day, and I was wondering if the virus could be on these items, and if so, should we disinfect them before handling them? And also, it was just in the news in our town or near here that a grocery store had an employee who was found to have the coronavirus. So as far as shopping, in your opinion, what's the safest way to get groceries? To shop on our own wearing mask and gloves, or using a store's personal shopper? I'm kind of concerned, like if a lot of the store employees might be sick or having the virus, what do we do? Thank you.
Thank you for the question. Dr. Weber, 2 questions there. Newspapers and other paper items like mail, and then, of course, shopping.
So let me start with the shopping. Obviously, with physical distancing, to the extent one can, one would like to stay 6 feet away from other individuals. I know many food stores are staggering the people coming in, but certainly home delivery would reduce one's risk of coming into contact with potentially infected persons. And I should say anyone who is sick, meaning with fever or cough or respiratory symptoms, should stay home and self-quarantine themselves at home. Obviously, if they become more ill, they should call their provider and not go out unless it's absolutely essential.
And Dr. Weber, let me just interrupt there and say that's even if they just think it's a cold, right?
Absolutely. There's nothing clinically that allows us as physicians or patients to separate what could be flu, and we still are seeing respiratory viruses like flu and RSV and COVID. The symptoms are quite the same: fever, cough, shortness of breath, can start off with a sore throat. One interesting symptom we've not seen with other diseases is loss of sense and smell, which can be an early indication of disease. And then as the disease progresses, more symptoms. But this could be exactly similar to flu. Also, things like muscle aches, fatigues can occur as well.
Now, Dr. Weber, Sandy wanted to know about objects. So she said if somebody in the supermarket has the virus and sneezes or coughs, touches items, and then they are brought to your house by, let's say, the supermarket through a delivery service, does she have to worry about wiping down the surfaces of the oatmeal or any of the other items? And the same question was true with regard to her newspaper or her mail.
Let me first start and say that this virus is not carried in food. So food is perfectly safe, and we're not aware of any foodborne spread of food. In terms of surface items, while this virus can survive, I'm not aware of outbreaks related to or transmission related to paper products, money, bags, and so on. It survives better at low temperature and low humidity and on more solid objects such as metal and plastics. So I'm not aware that those paper products really represent a risk. Obviously, if one was particularly concerned, then what you would do is take the food items out and then perform good hand hygiene and discard the bag.
Now, we have, of course, heard from the New England Journal of Medicine that the virus can be found up to, what is it now, about 2 or 3 hours in air in terms of airborne. That was an experiment. It wasn't real life. And they also found that things like plastic and stainless steel, there could be signs up to 3 days. So caution, of course, is appropriate.
Absolutely. Let me say that it's not surprising it's in the air. It is a droplet spread disease, meaning if I cough and you're within 6 feet, you can become infected. But this study should not be interpreted as meaning there's true airborne spread, which has not been demonstrated, meaning more than 6 feet. And it does survive in the air for short periods of time. This was a very artificial study where they injected virus into a drum. And again, it's not surprising, but this does not show long-term spread. Now, there is some good news in this.
Well, we do need to take a break. When we come back from the break, we're going to take more questions from our listeners. You can join the conversation via email. Terry, the address?
radio@peoplespharmacy.com. You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. KAYA Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's Kaya Biotics.com. Use the discount code PEOPLE for $10 off your first purchase.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
And by Cocovia, maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocovia.com.
Today, we have an expert on the phone to give you a live coronavirus update and answer your questions. To practice appropriate physical distancing, we're taking your questions by email, and that email is radio@peoplespharmacy.com.
Our guest is Dr. David Weber. He is professor of medicine in the Division of Infectious Diseases and professor of pediatrics at the University of North Carolina School of Medicine. He's also professor of epidemiology at the Gillings School of Global Public Health and medical director of UNC Hospital's Departments of Hospital Epidemiology. Dr. Weber is associate chief medical officer of UNC Healthcare.
Dr. Weber, can people without symptoms actually spread the virus?
So there's no question that individuals can be asymptomatic, that has become infected without any symptoms. Now, obviously, those people, by definition, are not coughing or sneezing, so their infectivity is probably much, much less, and we don't actually know to what degree such people can transmit. It may occur, but it's probably much less important than those who are more symptomatic and coughing.
Dr. Weber, Tom in Buffalo, New York would like to know, if you become infected at, let's say, noon on a Monday, how long is it before you become infectious to others? And how long after that infection before you exhibit symptoms?
So we do know quite a bit about the timeline. We know the incubation period from infection to symptoms can range as quickly as 2 days up to about 14 days. On average, it's about 7 days. And we do know that people have their highest viral loads, and therefore they're most infectious when the symptoms first begin.
We have a question from Alan in Dallas, Texas. How does a person who tested positive know when they are no longer contagious and can safely be around others?
So the guidance from the Centers for Disease Control is you are no longer contagious after 7 days from your onset of symptoms, plus at least 3 days asymptomatic, which they don't actually define as no symptoms, but dramatically reduced cough, no fever, off of any drugs that would suppress fever like Tylenol, and feeling better.
Now, this is a very similar question. It's from Jan. She says, our granddaughters are now home from college. If they have self-quarantined for 14 days at home, except for going to the grocery and walking outside, is it safe to have them come into our home? Alternately, could we meet in the backyard? We are seniors with lung problems.
So if they've had no symptoms in 14 days and realizing there would be some very tiny risk that they would have acquired it while they were out shopping, the answer is yes. They would be felt to be not have become infected, and it would be safe to have contact. Again, physical distancing is important in all cases, and if one wanted to be absolutely sure, certainly outside and physical distancing would eliminate even the slightest chance of infection.
Dr. Weber, I'm really glad that you used the term physical distancing instead of social distancing. Can you explain why you're now using that term?
Certainly, because what protects you is being 6 feet or more apart. We want people to be socially interactive. We want them to communicate on telephones, by Snapchat, by computer. We want them to be supportive of each other. It's very hard and a very stressful time for everyone. We don't want people to social distance. What it really is physical distance.
Dr. Weber, we have an email question from Charlene in Orlando. She says, my daughter was taken to the hospital 2 weeks ago with COVID-19 symptoms. She was not tested because she had no recent international travel. She had been on a plane flying from Orlando to New Orleans to Philadelphia, and all of those places have confirmed cases through testing. The question is, how long is the virus detectable?
So in people, the virus can be detected using a nasopharyngeal swab. The way we do a little thin swab goes to the back of, through the nose to the back of the throat. And virus is most detectable through the PCR test from the time of symptoms for about a week. After that, it often is undetectable in many people. The sicker you are, the longer you generally have detectable virus.
There's been a lot of controversy about the tests because we were very slow to roll tests out. Tom in Charlotte wants to know if the U.S. could have used the WHO published test protocol.
So I'm not specifically familiar with that. The issue here for the testing was, you're absolutely right. The tests have come online more slowly than we would like, and we even today have less testing ability than we would like. And the major impact of that is the numbers we've talked about, the greater than 100,000, may be an undercount because of not testing the outpatients who have mild illness. So that is the major impact of that. We so far have really had enough tests to test all the people generally who are sick enough to come into the hospital and require care.
Lewis wants to know, if a person recovers from COVID-19, will he or she be completely or partially immune from reinfection, and for how long?
So the best evidence suggests that, in fact, you would have a partial or complete protection for months to years with that, based on SARS and MERS. And I should say, very importantly for those people, there are now studies underway looking at convalescent serum for those who are 21 days since proven illness, taking their antibodies, which protected them and allowed them to recover, and then giving those to people who are now critically ill. Those studies are underway. That type of passive transfer of antibodies has been shown to work for other diseases, such as Ebola.
Can someone transmit the virus after they recover? And how long would they be contagious? We keep getting that question.
So again, the virus drops off fairly rapidly in people who are recovering. And as we've said, 7 days since onset of symptoms and 3 days since a dramatic decrease of symptoms. For the great majority of people, the virus will no longer be there, and you would no longer be contagious. The sicker people who are in the hospital and have severe pneumonia, they may have prolonged virus for till before they become asymptomatic. We're not aware in this disease that there's any chronic carrier state. So once you've recovered, then you don't carry the virus for weeks or months like we would carry some other viruses.
That's very good news. People have also asked if, after you have recovered, if you are then immune to catching it again.
The answer is certainly in the short term, that is almost certainly the case.
We have a question from Sally in Ottawa County, Michigan. She wants to know about physical distancing. How far away should people remain while passing others walking outside in a wooded county park, for example?
So ideally 6 feet, and if you're standing near someone, you just stretch your arm out, they stretch their arm out. If your hands touch, you're probably too close. But again, the virus has to travel in the air, and so passing someone, even if they were a little closer, 4 feet outside with wind blowing, would greatly diminish the risk than being indoors. And so it's a matter of how close you are, how prolonged the contact is, and then things like wind and other things that would disperse the virus.
Dr. Weber, do we have any idea why some people are more susceptible than others? And what I mean by that is, we've been told that roughly 80% get over COVID-19 pretty quickly without too much in the way of discomfort or serious symptoms. But that other 20%, including a fair number of people who are relatively young in their 20s, 30s, and 40s who don't have some pre-existing condition, some of them have gotten really sick and some have died. What is it about their immune systems or about some other factors that we haven't figured out that makes some people so vulnerable?
So we do know that particularly age, the older you are, particularly going up from age 60, makes you much more likely to develop severe disease and unfortunately die, particularly people over 80. The other thing is with many other diseases, underlying diseases such as diabetes, cancer on chemotherapy, and others make you at higher risk of having severe complications. But that's not to say that some young people in their teens, 20s, and 30s, it's just much less frequent for reasons we don't understand, can develop very severe disease, and some of those, unfortunately, will die.
Dr. Weber, William in Chapel Hill wants to know how to take care of yourself at home if you come down with symptoms and you're sick, but you're not so sick that you need medical attention. The question is, should you take NSAIDs? Should you take Tylenol? Can you take both? What do you do for cough? And what about asthma patients?
So first, let me say yes, that we do believe people who have underlying lung disease, such as asthma or chronic obstructive pulmonary disease, will be more likely. This is a respiratory infection to have more severe side effects. In terms of taking care of yourself, there's no specific therapy that we know of. So it's drink plenty of fluids, rest as much as you can. Some people have nausea and vomiting, but that's uncommon, so eat reasonably. Certainly, if you're having a high fever over 102, it's certainly reasonable to take either Tylenol or NSAIDs. If the Tylenol or the NSAID itself isn't working, stay within the recommended dose for your age or weight, and you can alternate the two medications there. Over-the-counter cough medicines certainly may help relieve the cough, and decongestants may help there. But most importantly, if you are having trouble keeping fluids down, high fevers, particularly if you have underlying diseases, then you need to call your healthcare provider. And certainly if you're very ill, you should call 911, but inform them that you might have COVID so that they could take all the proper precautions for their safety.
Amy asks, what can we do to mitigate the cytokine storm, and we will ask you what that is, that seems to be the lethal part of the infection? Can vitamin C help? Where do you stand with elderberry? So obviously some non-traditional treatments. There have been some hospitals in New York that are, I think, injecting people intravenously with high doses of vitamin C. It's been said that they've done that in China. I don't know if there is any scientific evidence to support that. But first, what is the cytokine storm?
So part of the body's reaction to any infection is we release these immune mediators that help us fight infection, but they also at times can damage the lungs and the other organs. And this is one of the reasons that we felt that young people had higher mortality in the 17-18 influenza were from these cytokines. There are things that could be used in the hospital, such as steroids, that blunt that response, but actually steroids are likely to increase the risk. So we really don't have any good way of blunting that response. Now, in terms of other things such as vitamin C and zinc, there is not any specific data I'm aware of yet about COVID. But for other viral respiratory illnesses, particularly helping you fight off a mild infection, there is evidence that vitamin C within reasonable amounts and zinc, when used appropriately, can help mitigate some of those symptoms. Elderberry, I'm not aware of any activity in this regard, but it may be present too. I'm just not aware of that drug.
We have seen some absolutely fascinating videos from an organization called MedCram, MEDCRAM.com, and they've talked about the role of zinc against COVID-19. And that's what they suggest, that the hydroxychloroquine malaria drug actually helps zinc get into the nucleus of the cell, into the cell itself, where it can actually exhibit some antiviral activity. So that's in vitro. Do we have any evidence that this drug could work in vivo, that is to say, in people? The pilot studies have been mixed, have produced mixed results. It seems that the enthusiasm might have been a little overstated in those press conferences last week.
So chloroquine is active against many viruses in the test tube. Hydroxychloroquine a little less active in the test tube. There have been studies of chloroquine for other viral diseases like dengue and flu, and it has not proved to be successful for the other viral diseases. There's at least one viral disease, chikungunya fever, for which chloroquine actually seemed to make people worse. So there are many trials ongoing in the United States. There are trials in China. Obviously, they're still pending. And we do have to be aware that the drug does have some cardiac toxicity. It can also cause problems from the nervous system in people with underlying diseases such as Guillain-Barré and others. So we have to use it cautiously in proper doses, and the trials will tell us, in fact, if it works. Probably, I would guess, within the next month to 3 months, we'll have trials being published that are properly controlled and give us good data. And
that's also true for the antiviral remdesivir, which is being tested around the world as we speak.
And the difference with remdesivir is, in the test tube at least, it is highly active against coronaviruses, including SARS, MERS, and COVID. This drug has not been tried for any other viruses, but it certainly one has high hopes that this drug might work. It's available on a number of trials and compassionate plea from the manufacturer, but as yet no data really on well-controlled trials.
Philip wants to know if he's staying home and he's uncertain about whether he should call his doctor. He hasn't been tested for COVID-19. What symptoms would impel him to seek emergency medical care?
So again, the symptoms of this are the standard symptoms that we would expect to see with any virus, such as influenza, particularly cough. Fever and shortness of breath are the sort of the key. Cough and shortness of breath have been the probably two most prominent ones. Certainly, people often have runny nose, sneezing, sore throat, profound fatigue, and myalgias, muscle aches. Again, these could all be just regular influenza. They could be the non-novel coronaviruses that we see, but it certainly could be COVID as well.
And seeking emergency care if you're having trouble breathing, right?
Yes, certainly if you have very high fevers, you are not able to take down fluids, you're developing a severe shortness of breath to the point where you really can't breathe adequately, can't eat. All of those would be indications to call your provider. If you're critically ill, obviously call 911.
You're listening to Dr. David Weber, professor of medicine in the Division of Infectious Diseases and professor of pediatrics at the University of North Carolina School of Medicine. He's also professor of epidemiology at the Gillings School of Global Public Health and medical director of UNC Hospital's Departments of Hospital Epidemiology.
We are going to take a short break briefly. When we come back, we're going to talk about some other potential treatments. We want to find out about a century-old vaccine called BCG. Why are they starting to administer this vaccine to health professionals in the Netherlands and in Australia?
And if the measures we're taking now to limit people interacting with each other are successful at slowing the spread of COVID-19, will it be safe to lift the restrictions?
We're taking your questions about coronavirus by email. You can join the conversation, radio@peoplespharmacy.com. Again, email us, radio@peoplespharmacy.com.
You're listening to The People's Pharmacy with Joe and Terry Graydon. This People's Pharmacy podcast is brought to you in part by Verizana.com.
Verizana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's PEOPLE, all uppercase. To learn more, go to Verizana.com. That's VERISANA.com. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by CocoVia, offering plant-based nutrients in the form of cocoa flavanols for brain and heart health, online at cocovia.com.
And by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
Today, the People's Pharmacy is a live coronavirus update with answers to your questions.
Our guest is Dr. David Weber. He is professor of medicine in the Division of Infectious Diseases and professor of pediatrics at the University of North Carolina School of Medicine. He's also professor of epidemiology at the Gillings School of Global Public Health. He's medical director of UNC Hospital's Departments of Hospital Epidemiology, Infection Prevention. Dr. Weber is Associate Chief Medical Officer of UNC Healthcare.
And Dr. Weber, we're extremely grateful to have you joining us today live on the People's Pharmacy. And we want to put a shout out again to all of your colleagues all across the country, around the world, the physicians, the first responders, the nurses, the allied health professionals, the respiration therapists, all of the people who are in the trenches right now trying to save lives. I want to ask you a little bit about BCG. It's been around for 100 years. We currently don't have a vaccine, but BCG is a vaccine. Can you tell us what it stands for, BCG, and what it's been used for, and why doctors are getting vaccinated in Australia and the Netherlands and a few other countries?
So BCG stands for a strain of a bacteria allied, similar but not identical to Mycobacterium tuberculosis, the agent that causes tuberculosis, and the vaccine has been used for 100 years to help prevent, particularly in children, from developing active tuberculosis. It is not specifically a vaccine against COVID, but it is a nonspecific stimulator of immune function. And by boosting the antibodies in general and the ability of the body to fight infection, there is hope it might diminish the risk of people acquiring COVID. And it's being tested now in Australia, I know, among several thousand healthcare personnel who are on the front lines, obviously caring for COVID patients as a way of reducing their risk of acquiring COVID.
Now, of course, what we're worried about are shortages. BCG is used for bladder cancer. It's incredibly effective. It's one of the early immunotherapies, but it can be very hard to obtain. And I'm worried that if there are positive responses in those health workers in Australia and the Netherlands and other countries, will we be able to make enough BCG for the population?
And that would be a major problem, particularly in the United States. In many parts of the world, BCG is given to every young child. In the United States, we haven't used this vaccine in decades because our rate of tuberculosis is so low. So particularly in the United States, unless we could get supplies elsewhere, at least in an immediate short period of time, having access to large amounts of it would be very difficult. In addition, in people who are immunocompromised, such as with cancer, as an example, or other severe immunocompromising conditions. BCG occasionally can spread within the body and cause a disease such as tuberculosis, so we would have to be cautious in certain subgroups of our population. It is a live bacterial product in giving it to certain people.
Dr. Weber, are there other treatments that are being tried out in various places that you are especially interested in?
So I think the most interesting one, if we've already mentioned, which is finding people who are now 21 days since the onset of their disease and have fully recovered, getting their antibodies from them and injecting it into individuals who are now critically ill. Again, it's been shown to work in people with Ebola. There's certainly some hope. I know they're beginning to try this in trials in New York. Of course, you have to be careful and not to transmit other diseases that are in the blood, such as hepatitis B or hepatitis C, but I think that's exciting. I know people have now screened many different potential therapies for activity in the test tube against COVID, and there are more than 30 potential other drugs that have been used. There are trials with some of the antiretrovirals, such as lopinavir, ritonavir, often combined with ribavirin. At least one trial did not show efficacy, but that's yet another set of drugs that's being looked at.
Dr. Weber, we have a question from a listener who has identified herself as S. She says, "This may be a stupid question. I've tried to find the answers through the CDC, but to no luck." She says they're saying people who have the virus and can show no symptoms. Is it safe to have sexual relations with your spouse? You couldn't accomplish that while staying 6 feet apart.
And that is certainly true. Again, the risk is when there is no evidence for this virus that it's transmitted through sex. There is no evidence, in fact, that when we've had pregnant women who unfortunately become infected, that it's transmitted from mother to baby, again, as other diseases like hepatitis B can. But, however, if you're within 6 feet of someone, and particularly if they are symptomatic, then there is the chance of spread from the respiratory tract from one person to another. So it's a question of distance, not a question of sex.
Dr. Weber, I am not absolutely certain about this, but I think yesterday I spotted a report suggesting that mother-to-baby transmission in utero might be happening in some cases.
We'll have to check on that, and we'll put it up on our website. We do have a caller from Cary. Rick, welcome to the People's Pharmacy. What is your question for Dr. Weber, please?
Yes, I've seen the many reports of what we should do with groceries and packages that come to our home, and they seem to be all over the map. Can you elaborate a little bit more on that? I understand the infection comes primarily from the proximity to other people, but I've seen things that keeping your groceries in the garage for 2 weeks to no time at all. So can you provide us a little more guidance in that area?
Sure. Let me first say there is some good news about this virus. It has an envelope, which means it's relatively easily inactivated. So if the alcohol or waterless hand products will easily inactivate this on your hands in 10 seconds. Soap and water removes it. And any standard disinfectant to wipe would also kill it. So certainly you could just get a disinfectant wipe. If you didn't have something like that, you could obviously just take some Clorox and dilute it 1 to 100. Those types of chemicals, disinfectants, would rapidly kill this virus. So you can wipe things down if one is concerned. I know there's been a lot of concern about transmission on paper products. I have not seen good data how long it survives on the paper products. And keep in mind, detecting it with some of the molecular tests doesn't mean it's live virus. And I've not seen any real studies or epidemiologic suggestions that there is transmission through paper products. But that doesn't mean it doesn't occur. If one wanted to be particularly cautious, we could just wipe things down with a disinfectant wipe.
Terry, you've done some research on the CDC website with regard to how to dilute bleach so it has antiviral activities. Do you remember what the formula is, roughly speaking?
Yes. If you have a gallon of water, you put in 5 tablespoons of household bleach. If you have a quart of water, you put in 4 teaspoons of household bleach. And again, if you don't remember that, it's good to check on it. Check the CDC website. They have detailed instructions on disinfection.
And we have it as well on our website.
Dr. Weber, we have an email question from Madeline. She says, I am a geriatric nursing care manager going out daily to see clients in assisted living communities when I'm allowed to go in. I have high blood pressure and I've been on lisinopril. I contacted my doctor about changing the medication and he changed it to losartan. It's my understanding that ACE inhibitors may increase one's risk of contracting COVID-19 and making it more complicated. Is this correct? And she also wants to know whether that's also true of ARBs, which of course is the losartan she's currently on.
So this is an area of active study, and it is true that the studies out of China suggested people with hypertension, as we talked about with older individuals, are more likely to have complications with COVID. Now, is it because of the hypertension or because of the drugs we just mentioned? There is indications that these drugs do alter the ability of the virus and how it binds to the respiratory epithelium and causes disease. And it may be that both of these drugs do enhance the ability of the virus to spread. How important that is in everyone and what overall role is not entirely known, but there is some evidence that they are detrimental in the sense of increasing the severity of illness with COVID.
Dr. Weber, as an epidemiologist, you, I am sure, have watched very carefully the statistics from China, Wuhan in particular. You've probably been paying close attention to what's been going on in South Korea and Japan, Taiwan. They seemingly have made pretty good progress against this virus. Whenever you see video of anyone in China, in South Korea, in Japan, everyone has face masks on. I mean, it would be, I think, culturally unacceptable to go out in public in China or South Korea these days without a face mask. In the United States and in parts of Europe, it's culturally unacceptable to go out with a face mask on. I'm just wondering whether a face mask provides any benefit either in the transmission, if somebody is sick with the COVID-19 virus, or to protect people from catching it.
So both are true. Certainly, when healthcare providers come into contact with somebody with known as suspected COVID, we do wear a face mask, and it does dramatically reduce the risk of disease by filtering viruses out. If you're sick, wearing a face mask decreases your risk of transmitting it, much like taking a tissue, sneezing into the tissue, and then discarding it. It's probably better to have it on to protect yourself if you're not ill, because if you give a good sneeze or cough, then the air will escape around the sides of the face mask. But they are protective. Unfortunately, as you know, face masks have been in short supply, and we would prefer allowing people, particularly if they're home, not wearing face masks to the extent they can, to preserve those face masks for the frontline paramedics and others who really need them.
Dr. Weber, we have an email question from Francis who wants to know if homemade face masks are of any use. And there has been a swelling of volunteers, people who are stuck at home, want to do something to help, and who are now sewing face masks to make them available where they are so very in short supply. So are homemade face masks any help?
Well, let me first off and start up by saying for my hospital and all over the United States, we really appreciate the public's response to helping us here at UNC and across the country. People have offered face masks, some that they have that are officially made ones, others homemade, food, many other things that they've done to support the people on the front lines, and that's greatly appreciated. But in terms of homemade face masks, the answer is no. The data would suggest that just knitting a cloth mask or cutting it really may increase risks. The face masks that are approved and that we use are designed specifically to filter out virus-sized particles. The cloth really doesn't have the same weave and the same filtering capacity, and by actually getting wet and humid from the breath may actually increase the risk of infection. So we don't actually recommend that, except possibly as an absolutely last resort.
I have a question from Gretchen in Greensboro. She wants to know, is there any evidence that high normal levels of vitamin D help fight off winter seasonal flu? If so, is it good advice to keep your vitamin D levels in high normal range? And, of course, we don't have any information about vitamin D against COVID-19. On the other hand, the healthiest immune system you can have, presumably the better off you're going to be overall.
So I think certainly in the winter, it's reasonable for everyone to take a multivitamin, particularly those that have B and C in them for the reasons that we talked about. There is really no evidence that D, as long as you are taking it in within a multivitamin, that pushing the level higher would help you. And there are some concerns about the fat-soluble vitamins A, D, E, and K, because if you take too high levels, they accumulate in the liver and could damage the liver.
Dr. Weber, Minta has a friend who is an ED physician and wants to know, what is the advice for this person to stay as safe as possible in current practice?
So the first thing for any emergency department physicians, and I just have so much appreciation for those people out on the front lines every single day, like our paramedics, providing care and with some slight, we hope, slight personal risk. Well, the most important things are, first, obviously, if you have any patient who is coughing or has any respiratory symptoms, you need to be wearing a mask, ideally an N95 if it was there, but certainly a mask, gloves, and practice good hand hygiene before and after any interaction with that person. Increasingly, hospitals, including the University of North Carolina, but many hospitals now have all of their staff, or all of the patient contacts, wearing masks. To do that, sometimes we need to extend the use, not one mask per patient contact, but extend the use, and the Centers for Disease Control does have guidelines on how to do that. So appropriate personal protective equipment, masking the patient if they have symptoms, trying to keep distance except when examining them, wearing gloves, and good hand hygiene are the best ways we have for protecting oneself.
Dr. Weber, can you tell us the proper technique for washing hands and using hand sanitizer, and what kind of hand sanitizer is best?
So the best type of hand sanitizer is one that contains 60 to 90% alcohol. Most of the commercial ones often contain emollients to be nice to the hand. You place a drop in the center of your palm, and that'll be on the instructions how much to put there. And you certainly need enough to cover all the skin. Rub your palms together, then rub the back of your hands. And very important, you need to interdigitate your fingers, rub in between your fingers, and you need to rub for at least 10 seconds.
And should you leave the alcohol on your hands and let it dry, or can you wipe it dry with a towel?
Ideally, you would leave it on your hands and let it dry. And I should say soap and water is done the same way. Put the soap into the palm, spread it across the palm, over back of both hands, and then between the fingers, and again for a minimum of 10, preferably 15 seconds.
Patrick wants to know, what % of a population needs to have developed immunity to reduce the risk of transmission? And is there a blood test that can tell you whether you are immune?
Well, first, the blood tests will be coming online in the near future, and they will tell you if you had disease, and therefore you are presumed immune. And that can be particularly useful for those people donating some of their sera to help people who are critically ill, but they would also know that they're immune. And particularly, say, for physicians, they could then volunteer to see patients with a limited risk of acquiring new disease.
I'm wondering if people have the blood test that reveals antibodies to the virus, especially healthcare workers, when they can go back to work and feel like, okay, I'm protected and my patients are protected. I no longer have virus.
So certainly we can get blood tests that would show that. But generally, the time it takes to develop positive blood tests with most other viruses is 1 to 3 weeks. So it really is not going to be a very efficient way for telling when people are safe to go back. That's either based on symptoms, as we talked about, a week since onset of your first symptom and at least 3 days with a marked reduction and no fever. You could do 2 repeat nasal swabs when you're asymptomatic, looking for virus. If those are both negative 24 hours apart, both would indicate that you're no longer infectious.
Stuart wants to know, can we expect the virus to move south into the southern hemisphere this spring and then back north again in the fall? What differentiates viruses that are seasonal and those that are not?
So respiratory viruses tend to be seasonal, and we see them in our winter. And if you go to the southern hemisphere, like South Africa or Australia, they see them in their winter, which, of course, is our summer. And there are felt to be several reasons respiratory viruses peak in the winter months in both hemispheres. One is we're more closely indoors because of the cold, so we have more exposure. 2, we heat our houses, which dries out our mucous membranes and may make us more susceptible. Plus, we tend to have, in the colder weather, lower temperatures and lower humidity, and the viruses survive better in the air. And in fact, if you're on the equator, you don't have those peaks. They just see those viruses throughout the year. And yes, I do expect that there will be a peak of COVID in the southern hemisphere in our summer, their winter. And yes, I suspect most likely we will see another peak here in the viral season in the next fall-winter.
Dr. Weber, there have been a lot of conspiracy theories that somehow this virus is man-made, that the Chinese military might have been somehow involved in that process. And the Chinese have said, no, it's the American military-industrial complex that was involved. Can you straighten us out on those conspiracy theories, please? Yes.
First of all, none of them are true. COVID, as did SARS and MERS, evolved from bats. These are bat viruses. Not entirely clear, complex why bats can carry so many viruses. If you know, they carry rabies and other viruses there. And then they occasionally, over hundreds of years, thousands of years, some of these bat coronaviruses leach over into humans, and then we get pandemics like we had with SARS and now we have with COVID.
Dr. Weber, Iona says, I received a BCG vaccination as a baby in an experimental program at the Cradle in Chicago in the 1950s. Because of this, I tested positive for TB as a kid whenever the skin tests were administered in school. Would that early vaccination help mitigate the effects of COVID-19 if I got it?
The answer is probably not. You certainly have, by virtue of having a positive skin test, you have some immunity to Mycobacterium tuberculosis, the bacteria that causes tuberculosis. But the feeling for BCG is that it gives you this big non-specific immune response in the weeks to maybe a few months after you have it. Having had it as a child, that immune response is long since diminished, and it's unlikely to be protecting you against COVID.
There has been word that the Cuban Medical Society has somehow created a alpha-2b recombinant interferon, and they are administering it in various countries, I think possibly even in Italy. Do we have any sense at all whether a immune modulating compounds such as this interferon alpha 2b recombinant might be helpful?
So the answer is yes. It is possible that the use of interferons might work. They obviously increase much like BCG, the ability of the body to fight infections, although in clinical treatments with interferons for SARS and MERS, they did not decrease mortality or decrease time to viral resistance. So we don't have evidence from other coronaviruses that interferons work. But again, this is a different coronavirus. And I think until we have a proven therapy, we should consider all of these possibilities for clinical trials.
Dr. Weber, Philip in Wellsburg, West Virginia, says, several years ago I was hospitalized for 5 days with pneumocystis pneumonia. I had completed 6 rounds of chemo and 2 years of a biologic for lymphoma. He understands that having had pneumonia once, he's more susceptible, and he's wondering whether, in addition to washing his hands and keeping his distance, aerobic exercise or using one of those devices they have in the hospital where the patient inhales at a controlled rate to increase lung capacity would help protect the lungs.
So it's certainly true people with underlying diseases such as types of cancer at higher risk. And it is also true that to the extent you live a healthy lifestyle, don't smoke, exercise right, appropriate diet, all of those decrease your risk of acquiring any of many infectious diseases. And I certainly recommend all of these for a healthy lifestyle.
Dr. Weber, people have found a lot of stuff on the internet. Some of it is excellent information and some of it is not. Do you have any advice for people on how to sort the wheat from the chaff?
Yes, I think the best websites are, of course, your local county and state health department websites. The Centers for Disease Control has an excellent website. And I think many academic universities, including the University of North Carolina, Johns Hopkins, many of those academic centers have excellent websites that provide wonderful information. And I would recommend going to those websites.
Is there any additional advice that we should offer our listeners?
No, I think what we need to do is be supportive of each other. The United States will pull together. We'll get through this. We need to minimize the effects of distancing on people who are older and have contact, and we do need to have social interactions, and then anything we can do to support our frontline personnel are critical. In the long run, obviously, we will get through this pandemic, but there will be pandemics in the future. And so we need the federal government and all of us need to support the infrastructure for us to fight the next pandemic by adequately training people in infection prevention and physicians and nurses in this and supporting the critical public health infrastructure that will allow us to successfully fight this epidemic and the next one.
Dr. Weber, we are almost out of time. Very briefly, your crystal ball, what you anticipate over the next couple of weeks in the United States and around the world?
So I think that we will see increasing cases for somewhere between 2 and 8 weeks. Hopefully, we will peak with our physical distancing and the cases will drop off. I suspect that different places will have different hot spots and will have different peaks. New York will have an earlier peak than probably Detroit. I think other hot spots will develop. We need to keep in mind that deaths will lag behind cases by about 2 weeks. So when the cases, even though the cases start coming down, unfortunately, deaths will increase. The physical distancing will have 2 effects. One is it will lower the number of people infected, and just as important, it will spread out the infection. So instead of having a sharp peak over just a few weeks, it may be over a number of weeks. This will allow us not to overtax hospitals, so everyone who needs care could be cared for in the hospitals. I worry about a second wave like we saw in 1917-18 with another wave, and we need to be prepared for it when we have viral respiratory season coming up in the fall.
Well, let's hope we have a vaccine by then.
And that is all the time we have today. Thank you for listening. Special thanks to our guest today, Dr. David Weber. He is professor of medicine in the Division of Infectious Diseases and professor of pediatrics at the University of North Carolina School of Medicine. He's also professor of epidemiology at the Gillings School of Global Public Health, medical director of UNC Hospital's Departments of Hospital Epidemiology, Infection Prevention. Dr. Weber is Associate Chief Medical Officer of UNC Healthcare.
Lynn Siegel produced today's show. Special thanks to Al Wodarski, who engineered. People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC. There's a lot that we still don't know, but if you'd like to learn more, you can visit our website at peoplespharmacy.com. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you so much for listening. Do join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.